Thank you very much. That was wonderful. Just as a disclosure, I am representing myself, not Anthem in any way. But I think it's really an exciting topic here to think about how we can evolve our public health infrastructure to improve the way that we diagnose and manage populations. And the CDC, in their list of 10 essential public health services that they updated in 2020, the first two items are really directly relevant. They're assessing and monitoring population health status and investigate, diagnose, and address health problems and hazards affecting populations. So exactly what we're talking about here today. I'm going to focus on the information infrastructure. There's lots of other pieces of public health infrastructure we could talk about, but I'm going to focus on the information infrastructure since it really played out as such an important part of the response to the SARS-CoV-2 epidemic. And I'm going to talk about it in sort of layers, starting first with terminology and information standards. And this is one of the great examples, I think, of a very effective response that we had. Organizations like LOINC and the American Medical Association that manages CPT codes were very proactive and early in releasing new codes and terminologies that would allow us to share data between healthcare providers, public health, and other organizations in computable and interpretable ways. That was wonderful. We have for very many years now been working hard to evolve healthcare information interoperability, to move healthcare data between different participants in the healthcare ecosystem in this country. And we've made good progress, but it's still somewhat limiting in the COVID pandemic in terms of the degree that we were able to aggregate data to bring it together. And there were some nice regional or local success stories there. There were health systems that took advantage of their data in New York City, for example, and informed the rest of the country early on. Wonderful. There were some collaboratives that formed that brought together data that helped answer questions. Health information exchanges like the Indiana Health Information Exchange that already had connectivity to the majority of providers, laboratory sources, and so on, both grew the span of connectivity that they had and the depth of connectivity that they had, for example, with public health agencies, and we're able to leverage that to good effect in terms of having good visibility into the pandemic in a particular region or state. But nationally, we struggled to bring together the data. And in particular, not just healthcare data, and people use different terms for it, but situational awareness data. How many ICU beds are there? How many ventilators are available? How many masks do you anticipate needing in the next week? Was an area where we really didn't do so well, and our infrastructure needs to be evolved further. There's also a piece of infrastructure I think we're missing today. Doesn't exist. It's been thought about and talked about, and the CDC has begun to put its toe in the water. But I think of this as knowledge-driven reporting. As many of you may appreciate in our country, because we have a very complex and federated healthcare delivery system, we're not going to send everybody's healthcare data everywhere or to one centralized place in most cases. And so for public health purposes, we report. We send a subset of data to public health agencies so that they can monitor predetermined, pre-identified conditions. But in an example like the SARS-CoV-2 pandemic, we really have a different challenge, which is the data, we haven't even identified it as a condition of public health interest. We haven't even identified it as a condition, as we talked about earlier today. But yet we need to begin to share information and data with public health about it. So we really need I call it a knowledge-based reporting process, a very flexible, agile way that we can say, golly, this is now a public health interest and concern, and be able to deploy to the thousands of systems, healthcare delivery systems, laboratories, and so on, across the country, a bundle of knowledge, if you will, and that could be expressed in different standards ways, but saying this is now something that's important and reportable to public health. And we really have no mechanism for doing that today. It really requires handcrafting in almost every system, this kind of extension, if you will. And this is where there's different approaches to that. The health information exchanges could be the intermediary for doing that and reduce the number of places that information needs to be shared, but still an ongoing challenge. The fourth technology thing I want to touch on briefly is outbreak detection. We're talking here today about diagnosis, and in many ways, outbreak detection is exactly like diagnosis. We start with some prior probability. We use data to increase our confidence. We're never 100 or rarely 100% sure. And in particular, outbreaks are very difficult in the sense that if you wait till you're very sure that there's an outbreak, the horse is sort of out of the barn. Our public health interventions, our opportunities to intervene become much more limited. And so outbreak detection becomes a very important capability. And the CDC actually has some fairly advanced outbreak detection capabilities, for example, for influenza, the ILI-net, which if you look back, and I've not seen anything written or described whether the CDC actually saw or used ILI-net, but in retrospect, you can certainly look at the ILI-net data and say, golly, there's COVID coming up. The next thing I want to comment on real briefly is the policy challenges. And I'll come back and touch on this, but the fact that we have a federated public health system, local health departments federated to states, federated to the national, and the limits and challenges that creates in terms of information sharing. And also our national, and this isn't evil or wrong, but our concerns about privacy and the individual sort of determination. Many years ago, we put in place in at least 38 states or so, the model state emergency health powers regulation. But in the case of COVID, our legislatures in several states overrode those powers. The governor would put in place an emergency order and the legislature would second guess and override those. And the last thing I want to touch on briefly is sustained efforts. Many of you on this workshop may recall anthrax in 2001 and syndromic surveillance and looking at pharmacy dispensing events and pharmacy sales of over-the-counter products as an early indicator of outbreaks and so on. Lots of phenomenal efforts put in place, lots of information technology put in place. And in fact, in 2009 with the H1N1 influenza outbreak, those things worked reasonably well. Unfortunately, we have trouble sustaining attention and investment in these areas in this country. And like with the 2008 economic crisis, the fact that there weren't any large bad epidemics for a while, even though there was Ebola and Zika and so on, our investment and so on seemed to wane and our effectiveness fell apart. So the couple of things I think are worth pointing out as takeaways. First is that as with so many things, technology is not the rate limiting thing here. We know how, we have the standards, we have the technologies needed to have the data visibility that we need. It's much more about using what we have. And the Office of the National Coordinator convened a task force last year, and they produced what is really quite a nice, very detailed set of recommendations of what do we need to do to advance that. I think our policy and legal limitations require much more work. Our federated model, those privacy challenges, perhaps moving from a reporting to kind of an interoperability model for public health could be really important lesson learned here, things that we need to advance to move ourselves forward. And alongside that, and no surprise to folks in this workshop, I think, but the absolute requirement for sustained effort over time to have the systems in place, not to try to put the systems in place, to exercise those systems on a regular basis. Maybe hopefully we don't have another COVID pandemic right away, but there are other outbreaks, other opportunities, and we've heard about some of those during the workshop today, to exercise those systems, test them, make sure that they work, and do what we need to do so that when we do face a pandemic, we're ready to go. And then lastly, and I mentioned this earlier, I think a new thing that we need to put some time and energy into is developing an agile mechanism for adapting to these new situations like the COVID pandemic, the policy issues, and the technologic mechanism that enables those. So thanks very much for your attention. Look forward to the discussion.